and welcome everyone to the 9th annual Critical Care Symposium. I'm Mike Winters from the University of Maryland School of Medicine here in Baltimore, Maryland. We are so happy that you are joining us this morning for our Critical Care Symposium. Much like we've done in prior years, we're going to focus this morning's discussion on a singular topic, and that is shock. And we're going to talk about a whole variety and various types of shock. We're going to get things started with a warm-up discussion on really what to do in the first 10, 15 minutes of patients who come in and they may be sick. So some pearls for undifferentiated shock. And then we're going to touch on things like septic shock. We're going to touch on hemorrhagic shock, cardiogenic shock. And then we're going to have some deeper dive discussion on, well, right-sided shock or PE. And then a great discussion on, well, once we've thought about those main categories, sepsis, cardiogenic, hypovolemic, hemorrhagic, and the patient's still sick, well, what are those rare causes of shock that we don't see that often, but should be thinking about? So very much looking forward to our lectures this morning. And we are so happy that you've joined us from around the world. We know hundreds of you are joining from around the world, and many of you are actually gathered around a fire pit in the backyard over in Howard County. So thanks so much for joining us this morning. I do want to send a huge shout out to Dr. Michael Bond. He is one of our faculty professor of emergency medicine. He is our director of virtual education, multimedia. He has done really the lion's share of the work in bringing this symposium to you from across Maryland, across the US, and across the world. So thanks so much, Michael, for what you've done in preparing this and all of our UMEM lectures. Before getting started, I do want to just take a moment and send our most heartfelt thoughts and prayers from the University of Maryland Department of Emergency Medicine out to everyone in Texas that has been affected by the tragedy that's occurred over the last 24 hours, with so many children losing their lives yesterday in a horrific act of violence, not only for those children, the adults who have lost their lives, but the families who have been impacted forever, along with our EMS colleagues, pre-hospital providers, and emergency medicine colleagues who cared for those who were wounded from that event. You have our thoughts and our prayers over the coming days. Well, with that, I am going to turn things over, and actually I'm going to get started with our first discussion, and that is going to be on undifferentiated shock. Let me hit play here. And to that end, as I mentioned a few minutes ago, we are just going to touch on a few things that we should think about in terms of when patients come in that first 10, 15 minutes when they arrive, either walking into the emergency department or being brought in by EMS. So what are a few things that may make the difference of whether we can successfully resuscitate patients or perhaps they have a poor outcome? Now, I'll show this slide just once. None of either myself or none of our speakers this morning from University of Maryland have any financial disclosures. And to get things started, those of you that have heard me speak before, I really like a handful of quotes. And this is one of the quotes that I very much enjoy. And I like to substitute patients for that word people. And patients come into our lives for a reason, a season, or a lifetime. And even our graduating residents, in fact, perhaps our interns, over this past year that you've been practicing, I would bet that you can think of a handful of patients that you're going to remember for quite some time from a learning experience or some type of care that you provided, where things that either went well or maybe not so well in that patient's care. And one of those patients for me came in a few years ago, and that is J.E. J.E. is a 37-year-old gentleman who was brought in by Baltimore City paramedic for weakness and a perhaps episode of syncope. He has a past medical history of bipolar disorder, depression. He has cirrhosis secondary to hepatitis C and prior chronic alcohol use. And he has chronic low back pain. And essentially, for the week preceding his presentation to our emergency department, he had had an exacerbation, a non-traumatic exacerbation of his low back pain. There wasn't any red flags related to that. We're not in a spinal epidural abscess or metastatic disease kind of back pain emergency, but he'd had an exacerbation of his back pain to the point where it had been debilitating for him and he'd been unable to make it to his methadone clinic for several days. Now, on that Saturday morning, he reported that he was lying in bed and had this episode of rigors or shaking chills, and he felt really, really bad. Got up to go to the restroom, and his significant other noted that when he stood up and took a step or two, he fell back onto his bed and may have had a brief episode or loss of consciousness. Well, his significant other activated 911. They arrived, and EMS reported that when they got there, his blood pressure was 81 over 44 millimeters of mercury. Didn't look toxic or critically ill, but they brought him into our emergency department. Now, on that Saturday morning, thankfully, we actually had open beds. And so JE was put right into room 9. And these were his initial presenting vital signs when we hooked him up to cardiopulmonary monitoring. So take a look at these. Does any vital sign jump out at you? Wasn't markedly hypotensive, wasn't tachycardic. Finger stick was adequate for him having just generalized weakness. He wasn't febrile and he wasn't hypoxemic. And on physical exam, overall, JE was conversant with us. He was alert and oriented ×3, knew what was going on, gave us that HPI I just presented to you. No signs of scleral icterus. Maybe his conjunctiva were a little bit pale. His mucous membranes were mildly dry, but no JVD. Lungs were clear to auscultation. Cardiovascular, really nothing to write home about. No murmurs, rubs, gallops. Wasn't tachycardic, as I mentioned. Now, his abdomen was slightly protuberant. And recall he had a history of cirrhosis, and it was mildly tender. But JE had said that it's kind of feeling the way it always feels. It's the same with his back. So with this exacerbation of back pain, rolling him to one side, he had no midline lower thoracic, no midline lumbar tenderness to palpation, no CVA tenderness, no real signs of peripheral edema. And for this potential syncopal episode, his exam was non-focal. And this was a complete neurologic exam. So cranial nerves, motor were all normal. There was no pronator drift. Cerebellar function was intact. Speech was normal. Really a non-focal physical exam. So within that first few minutes, he's connected to cardiopulmonary monitoring. Because he may have had a syncopal event, we get a quick EKG, which really didn't show anything. So no concerning signs, no prolonged QTC, no signs of WPW, Brugada, pre-excitation, ARVC, anything that we would be concerned about with syncope, no signs of ischemia. And shortly thereafter, so about now 10 minutes into JE's presentation, we've gotten our HPI, a quick physical exam, gotten this 12 lead. Unfortunately, we're unable to get IV access, and then the base station goes off. Not only does it go off with one, but it goes off with 2 back-to-back acute stroke alert patients. And so we then needed to go address acute brain attack patients arriving. And it wasn't until, unfortunately, close to 3 hours later, after addressing those acute brain attack patients, that we made it back into room 9. And finally, we're able to establish peripheral IV access using ultrasound guidance, started to get some labs, started to give JE some IV fluids, and then went back to reassess those acute stroke patients. Well, within about 60 minutes, the overhead came across blue team, pick up line 1. It's the lab with a critical value. And so picking up that phone, in fact, the lab was calling because a lactate had been sent and JE's lactate returned at 11.2. And I kid you not, I had literally hung up the receiver from taking that panic lab call or critical lab call when our nursing colleague who was caring for JE came out of room 9, came into our provider area and said, "Do you mind coming back in the room? Because he just doesn't look so good." And upon walking back into the room, we found JE to be acutely altered. And these were now his vital signs that were flashing on the cardiopulmonary monitor. He had dropped to essentially 65 over 40. He was now markedly tachycardic, almost to 130, and he was quite tachypnic, up from the low 20s now to close to 30. And we had lost hours on JE's resuscitation. And it's really with his case that I will always take with me in terms of subtle presentations of really critical illness. He clearly had presented in and had some potential subtle signs of shock that, had I picked up on earlier, I may have been able to intervene and change the ultimate outcome for JE. So let's talk about just a few things as we get warmed up here on our critical care symposium, introducing this concept and talking about shock. Really at the end of, let's say, well, the next 20 minutes, just giving you a few pearls with respect to the initial assessment of patients with potential undifferentiated shock. A few pearls on that stabilization. Once again, what do we want to think about and do in the first 15 to 20 minutes of these patients' presentation? And then an approach. So when patients present overtly critically ill, we've got to do things simultaneously. Assess them, start to deliver interventions, and then also we as the provider, as the physician, we need to think about, well, while we're doing these things, what is actually the cause of this patient's undifferentiated shock or critical illness? And those are the things that we're going to focus on over the course of our next 20 minutes. Well, with respect to shock, you all know this definition exceedingly well. It is simply inadequate oxygen delivery to meet the metabolic demands of tissues or cellular function. And we know that we are absolutely on the clock for this condition, because if we don't intervene in a timely fashion, that inadequate O2 delivery leads to cellular dysfunction, leads to organ dysfunction, leads to multi-organ dysfunction, ultimately critical illness, and can lead to patient death depending on the condition. A very time-sensitive critical illness that we encounter, dare I say, almost every day in our emergency department. Now, in terms of those time-sensitive conditions, you know this list exceedingly well, like the back of your hand. Sepsis, that hemorrhagic or hypovolemic patient, the ones with obstructive potential, obstructive physiology of shock, from PE to tamponade to tension pneumo, the cardiogenic shock, and then the vascular catastrophes. You know this exceedingly well, but one pearl that I would say is it has been studied in an ED patient population. If you were a betting person and you unsure as to what the etiology of a patient's critical illness is, more than half the time, it's actually going to turn out to be sepsis. So when this has been studied in an ED patient population, about 62 to 63% of patients with undifferentiated shock in the emergency department ultimately turn out to be sepsis. So pearl number one. Now, in terms of the clinical presentation, this is where it's often hard to pick up patients who have subtle signs of critical illness, because initially they're going to present with very non-specific symptoms: generalized fatigue, generalized malaise, weakness. They may report some type of dizziness. They could be altered. So an older patient, an elderly patient, simply presenting with altered mental status could be a sign of very poor CNS perfusion. And then syncope, much less a rarer presentation of overt shock, but these non-specific symptoms. And to get back to JE's case, well, actually he had presented with two of these. He had come in with generalized weakness and had a brief syncopal episode at home, which resulted in the activation of EMS. Now, as we transition to the end of one academic year and begin anew, we've also had many new students start with us here at the University of Maryland in our emergency departments, not only at the medical center, but across our system. And I think in many cases, many of us have taught that consider shock in the patient who presents with overt hypotension. And certainly that may be true, but I think as another pearl, it's very important to state that while we often think about hypotension being a component of undifferentiated or shock, it actually isn't required for the diagnosis. In fact, in many patients, the onset of hypotension is not going to be till later or much later into their critical illness. And many of our patients in the emergency department exist in this state of what's been referred to as cryptic shock. In other words, Their blood pressure, their mean arterial blood pressure, is not something that jumps out at you as overtly low, but they clearly have signs of decreased organ perfusion, whether that be altered mental status, whether that be decreased urine output, whether that be cool or clammy skin, or whether that be an elevated lactate. And when this has been studied, patients who have overt hypotension versus those that have cryptic shock, the mortality, the in-hospital mortality, exactly the same, which stresses the importance of picking up these subtle signs of shock and critical illness. And to that end, I know that this is a little over a decade in terms of this study, but this is one of several studies that has examined what about the patient in the emergency department who our nursing colleague comes out and says, so-and-so dropped their pressure. I gave them a little bit of a fluid bolus and they're back up. Well, does that episode of non-sustained hypotension actually make a difference? Is it important? Yes. So once again, this is just one of a few papers that has looked at this non-sustained hypotensive episode in the emergency department. In this particular study, in over 700 patients, that 1 out of every 5 had an episode of non-sustained low blood pressure, and it did result with an association of a significant increase in in-hospital mortality. Now, I'm definitely not saying that every time somebody has a non-sustained drop in blood pressure, that they always require admission. But what it should prompt us to do is to go back and reassess that patient to ensure that there are no progressing signs of subtle illness or perhaps overt shock. So from a presentation standpoint, thinking about vital signs, beware of that non-sustained episode of hypotension, go back to the bedside, reassess that patient, and above all else, recall that hypotension is not required for the diagnosis of shock. If you're going to lean on one vital sign abnormality that would clue us in to critical illness or potential shock, pay attention to tachypnea. This is often the most specific finding of critical illness in our sick emergency department patients. If you're looking at a patient and you are truly counting their respirations and they are tachypnic, start to be worried, start to think there is something that I need to diagnose in this patient. And when I get back and take a look once again at J.E.'s case, he had that episode of non-sustained hypotension. Now, ideally for him, that was in the pre-hospital setting and he arrived not overtly hypotensive. And then if you recall his vital signs when we took it initially and upon entry into room 9, he was tachypnic at 24. So thinking back on this presentation, he had that non-specific finding of weakness, syncope, didn't really pick up on that. And then he had the non-sustained low blood pressure with EMS and was tachypnic upon arrival. Now, what about just a few quick physical examination pearls? And think to yourself, how often in assessing someone, just like J.E.'s case, do we take a look at the peripheral circulation? And I would argue we have 3 windows into organ perfusion. I had mentioned already the CNS, so someone presenting with altered mental status can be reflective of poor or inadequate CNS perfusion. If we've got someone who we're monitoring urine output and it's going down, that's a marker of decreased renal perfusion. But when we're first assessing patients like JE, I would encourage you definitely take a look, take off their socks, take off the pants, take a look at their hands and their feet and assess their circulation, assess their peripheral circulation. This is often your first window into the adequacy of perfusion. Are the hands and feet cool and clammy, or are they flushed? And that can give you some pearls into ultimately the etiology of that patient's shock or critical illness. Take a look at the neck. Now, I'm confident that you looking at this neck, we're not going to miss this jugular venous distension. And sadly, this was a patient that came into our emergency department in a state of shock, had markedly elevated, you can see, JVD that turned out to be due to a pericardial effusion, which ultimately was a malignant pericardial effusion as the initial presentation of breast cancer in this young female. So take a look at the hands, the feet, take a look at the neck for jugular venous distension, and then in applicable patients, actually consider an early rectal exam. Many of the faculty watching, many of our senior residents can probably attest or raise their hands as to when have you had that patient come in, they look sick, and then you get things started an hour, hour and a half, 2 hours later, our nursing colleagues come to you and let us know that, well, they just had a voluminous Melenic stool in the bed, and we've gotten hours behind with respect to resuscitating a massive GI bleed. So in terms of physical exam pearls, once again, hands, feet, look at the neck, and then consider a rectal exam, especially in someone who may be on anticoagulants or who has a prior history of GI bleed, can be enormously beneficial in that first 15 minutes or so of their evaluation. Now, a few other quick assessments. You're going to check a glucose, you're going to get an EKG, looking for perhaps signs of ischemia, thinking about a cardiogenic component, getting an HCG in females of reproductive age, and then definitely not forgetting the type and screen, especially in someone who you feel has critical illness, who has overt shock. If it turns out to be a GI bleed, we don't want to then wait another 30 to 60 minutes to be able to give them appropriate resuscitation with blood products. And then we send a lot of lactates. And in this particular case, thankfully, the senior resident working with me on Blue Team that day did add a lactate onto JE's evaluation. And as you saw, and as we talked about, came back markedly elevated at 11. And that came back just ahead of his overt decompensation. So casting a wide net, once again, this is in the first 15, 20 minutes of someone's resuscitation, you're picking up, and there are these subtle clues that this patient could be sicker than outwardly presenting. Consider sending a lactate. So let's switch from the assessment pearls kind of into just a few stabilization pearls as we drive towards the end here of our time in the first discussion. Well, with shock simply being inadequate O2 delivery to the tissues, go ahead and just put someone on non-rebreather. Provide them with supplemental oxygen. And yes, in other critical illness states, we've talked about the potential harmful effects of hyperoxia. But in this particular case, the first 20, 30 minutes of their resuscitation, provide them with supplemental O2. You are going to get IV access, and looking to get peripheral IV access to deliver large volume resuscitation if needed. You know this exceedingly well. If you can't, and you're looking at IO access, well, consider perhaps the humeral IO in contrast to, say, the tibial IO. There's been some literature in resuscitation that suggests that, well, you might be able to get more volume in, if needed, with a humeral IO. And then ultrasound-guided peripheral IV. One aspect of IV access that I'm just going to touch on briefly here is the use of midline catheters. And this is from a former colleague of ours at the University of Maryland, Dr. Rory Spiegel. Many of you know Rory from many social media platforms in terms of what he teaches and writes. This is one of his studies that he published based upon the midline experience when he was a resuscitation fellow at Stony Brook, in which they placed them quite often for patients undergoing active resuscitation. We've started to place them here at Maryland when Rory was with us. I'll admit that it has trailed off a little bit, but this is his paper from Annals of Emergency Medicine looking at midline catheters in the ED. And essentially, midline catheters, as you know, are either placed in the brachial, cephalic, or basilic veins. And in their hospital protocol, it was for patients, say, like JE, difficult IV access, needing active resuscitation, or perhaps vasoactive or inotropic agents. And essentially what they did is had a relatively focused, not onerous, but a focused training of the placement of midline catheters with a didactic discussion, simulation, and then observation of their placement. In Rory's paper, they placed over 400, most of which, or about half, was in the basilic vein, most of which were needed for active resuscitation, so when JE crashed. And you can see here that really after a median of one attempt, they had 99% successful placement with an exceedingly low complication rate. In fact, the incidence of severe complications, less than 1%. So we've moved on from the assessment. We're stabilization pearls, putting the patient on supplemental O2, getting some type of peripheral IV access, and then initiating resuscitation, and often we're reaching for those IV fluids to initiate someone's resuscitation while we're also thinking about what could be the etiology of this patient's critical illness. And I know many of you are watching in terms of IV fluids and thinking about this balanced crystalloid versus normal saline. I do think it's very important. We've had in the last, I guess now 7 to 8 months, 2 articles that are important to review that have taken a look at this. It's the Basics trial. This was published in August, I think, of JAMA, and then the Plus trial just published in the last 2 to 3 months in the New England Journal of Medicine. So I do think it's important to at least touch on these studies. I'm not going to do a deep dive here on the Basics trial, but recall that this was an RCT done out of many centers in Brazil, or many ICUs in Brazil, that took a look at 90-day mortality in ICU patients who got either randomized to a balanced solution that was Plasma-Lyte 148 or normal saline. And in that particular study, the use of Plasma-Lyte 148 actually did not reduce 90-day mortality in these ICU patients when compared with those that received normal saline. Now, with respect to the Plus trial, that's the much more recent one that is in the last 2 to 3 months. Let me spend a few minutes on this particular one. This was multi-center out of Australia and New Zealand. Same objective, looking at this balanced multi-electrolyte solution, which also turned out to be Plasma-Lyte 148, and looking at 90-day mortality in ICU patients. So they included adult patients in the ICU, not in the emergency department, not presenting in that what we would term salvage phase of resuscitation. But these patients in the ICU were deemed to need fluids and to be in the ICU for at least 3 days. And in essence, they were randomized to Plasma-Lyte 148 versus normal saline. And they got that particular randomized fluid during their entire ICU stay. And they followed them up to 90 days. If they were in the ICU for 90 days, they got that same randomized fluid. However, if they left the ICU, once they got out to, say, a step-down unit or the floor, well, they didn't regulate the type of fluid that that patient got. So there was a whole mix of IV fluids beyond that, but they still looked at 90-day all-cause mortality with some typical secondary outcomes that we would normally see in critical care studies, such as the duration of length of stay in the ICU, in the hospital, duration of mechanical ventilation, need for renal replacement therapy. Overall, the Plus study had 5,000 patients, and you can see just about half actually came to the ICU from the OR or the PACU. So not necessarily the patients such as JE who crashes in front of us in the emergency department. So that's an important thing to consider when thinking about the Plus trial. Now, the reason I mention this is because it's a little bit different than the other fluid trials that we've talked about in previous years. Recall that in those trials, say the SMART trial, the one out of Vanderbilt, or even the Basics trial, when you look at the median volume of fluids that patients are getting in these trials, looking at balanced crystalloid versus saline, usually it's on the order of about 1.1 to 1.5 liters. In the Plus trial, you can see the median volume was closer to 4 liters, so a little bit larger volume resuscitation in these patients. And well, the take-home message was there was no difference in that 90-day mortality between critically ill ICU patients that got Plasma-Lyte 148 versus normal saline. No difference in the secondary outcomes, but some things with any study, just to think about. In August of 2020, they ended up stopping this early, primarily due to enrollment, primarily due to fluid discussions, debate around the relatively early COVID pandemic and what we were doing with IV fluids at that time. They then went back and reran all their numbers and recalculated their sample size to ensure that they achieved statistical significance. So there is some EBM manipulation with respect to the Plus trial, but it's an important, these two, the Basics trial and the Plus trial, are certainly important contributions to the fluid literature. So having said that, it's important to remember that it didn't change in this critically ill patient population, whereby at least 50% came out of the OR. Do I personally still lean towards balanced fluids? Those of you sitting with Dr. Dubs in the backyard know that certainly I continue to like balanced fluids. And I will say that while I'm not presenting it, there is a meta-analysis that got published that includes the PLUS trial data, the BASICS trial data. And that's still that meta-analysis taking everything into account. There still seems to be a signal of mortality benefit in the utilization of balanced fluids, but it is important that we are aware of these two latest studies. And finally, in terms of stabilization pearls, getting IV access, delivering an IV fluid to initiate resuscitation, and then for patients who have a very poor perfusion, a woefully low MAP, or really low diastolic pressure, concomitantly initiating vasopressor therapy. And those of you that are working with me and all of the faculty at Maryland know that we readily start peripheral vasopressors. But some of you watching from around the world still haven't been able to make the jump from initiating pressors via a central line to a peripheral line. And I hope this particular study, this is the latest, you can take to your directors, administrators, and really make the push to no longer needing or requiring central venous access in your ED to start peripheral pressors. This is a shout out to one of our later speakers. So Dr. Quincy Tran is going to end our symposium. He's going to talk about pearls for hemorrhagic shock. Quincy's one of the latest papers, this was in the American Journal of Emergency Medicine, to take a look at the complications of peripheral vasopressor administration. So some of our residents were on this paper with Quincy, looking at the prevalence of complications, whereby they did their systematic review. They looked at all of the appropriate studies, and their primary outcome was what were the complications of peripheral vasopressors. They had 9 studies, just shy of 2,000 patients in their overall systematic review and meta-analysis. And you can see 7% adverse event rate. But when you looked at the events themselves, 4 of those were considered major, and all 4 of those were actually a peripheral venous thrombosis that didn't require any treatment. So very safe in terms of administering pressors via peripheral IV. So we've hit on some initial assessment pearls, stabilization pearls, placing the patient on supplemental O2, getting that peripheral IV access, adding midlines to your armamentarium, administering IV fluids with now the knowledge that there are 2 relatively large RCTs out there that don't show a difference in 90-day mortality in ICU patients who were randomized to plasma-lyte versus normal saline, and then concomitantly administering norepinephrine during the resuscitation phase of these patients who have inadequately low mean arterial pressures or signs of poor peripheral perfusion. All right, last area here, and then we're going to wrap up in these last few minutes. So recognizing clinical illness with a few, or critical illness with a few of those pearls, the stabilization pearls, but in the first 15 to 20 minutes, we have to think, what is going on with the patient? What is the etiology? And I went through that list initially as we got started with this discussion, knowing that about 60% of the time, at least in the ED, it's going to turn out to be sepsis. But what if it's not? What about the etiologies of shock? And many of us have taught, well, consider this mnemonic as a quick way to remember the causes of shock. So we're well versed with this. So sepsis, our hemorrhagic or hypovolemic, our obstructive forms of tamponade, pneumothorax, PE, cardiogenic, and well, a little bit of editorial excuse here, K for anaphylactic or refractory anaphylactic shock as an etiology of this patient's critical illness. But thinking about these various 5 categories, sometimes that's even hard to remember as the alarms are going off and the stress is in the room and someone's starting to decompensate, say when we're now back in the room with JE. Really, here's where ultrasound comes in, and really utilizing, leaning heavily on ultrasound, evaluating patients with undifferentiated shock in those first 15 to 20 minutes can give us a tremendous amount of clue. And I very much, while the rush protocol gives us thoughts on how to perform the ultrasound, I very much like the Rush way of thinking and taking those 5 big categories of shock and really condensing it down to just thinking about 3 and thinking about the circulatory system, as we know, with the heart as the pump, the venous system as the tank that holds the fluid, and then the pipes that connect the two. So taking a step back and thinking about larger etiologies, but now just bringing it down to just 3. Is this patient shock due to a pump problem, a tank problem, or a pipe problem? Using our ultrasound to determine first, is it with the heart? Is there a mechanical obstruction? Do I have tamponade? Do I have signs of a PE? Or do I have signs of a very poor squeeze? So now I can either perform a pericardiocentesis in the first 30 minutes, think about working with our ED pharmacist to draw up thrombolytics for a massive PE, or also asking them to draw up inotropic agents if someone has cardiogenic shock, which we'll hear about in a short bit from Dr. Tuwaldi. If it's not a pump problem, is the etiology of shock due to a tank issue where it's either empty because they're overtly hemorrhaging or markedly hypovolemic? Do they have trauma and they have hemoperitoneum or hemothorax? Or do they have a tension pneumothorax? So once again, in the first 30 minutes, I'm either continuing with fluids or giving blood products, arranging for the patient to go off to the OR with trauma surgery, or decompressing the chest. And if it's not a pump, it's not a tank problem, do I have a pipe problem in terms of a vascular catastrophe with the aorta? And also thinking about pathologic vasodilatation, thinking about sepsis as a pipe problem, and then anaphylaxis. And the final 2 pearls I'm going to leave you with, one of which is anaphylaxis. And that is, don't take it off the table when the patient first arrives. And that's because in the first, so let's say 30 to 40 minutes, there's going to be anywhere from 10 to 20% of patients that ultimately have anaphylactic shock that will not manifest the skin or cutaneous findings that were so common so used to seeing in the setting of this allergic emergency. We're looking for urticaria, we're looking for angioedema, but up to 20% may not initially present with those findings. So still keep anaphylaxis on your differential. And the last pearl I'll leave you with in terms of undifferentiated shock is in the markedly tachypnic patient. The respiratory muscles are avid consumers of oxygen. And once again, shock is simply inadequate O2 delivery to the tissues. And so while the patient may not have overt respiratory failure with refractory hypoxemia or significant hypercarbia, if they're markedly tachypnic and they're in a state of shock, you may end up needing to intubate them. All right, so I'm going to wrap up here to keep us on time for our symposium. And just to let you know, well, what ultimately happened with JE? Recall that he had this episode of non-traumatic back pain that had gotten worse over the past week. He actually was unable to make it to his methadone clinic. And as a result, what he admitted to later is given the extremes of back pain, he was really markedly increasing his anti-inflammatory or his NSAID dosing over the course of that week. He had that episode of shaking chills in his bed at home, got up, had an orthostatic syncopal type of event, had that transient hypotension, came in, had the pale conjunctiva, reported weakness, reported syncope, had mild tachypnea, all those signs that something was going on. And then we got the elevated lactate. Shortly after we went back in, he's altered, he's hypotensive, and it was then that he had a huge melenic stool, ultimately due to an enormous gastric ulcer induced by NSAIDs. So he ultimately had GI hemorrhage as the result, or the etiology of his shock. So in wrapping up, it's just a few pearls to think about with undifferentiated shock. The first 10, 15, 20 minutes, beware of a single episode of even transient hypotension in the emergency department. That doesn't mean go admit everyone, just at least go back to the bedside, reassess that particular patient. And if anything, any vital sign abnormality, pay attention to tachypnea. It's one of the most specific vital sign abnormalities of critical or subtle illness. So pay attention to tachypnea. When you're initially assessing patients, be sure to look at the hands, look at the feet. That's one of your 3 windows into the adequacy of peripheral perfusion. In JE's case, having risk factors, or let's say for GI hemorrhage, consider an early rectal to avoid being hours down the road and then diagnosing your GI bleed. And then consider a lactate in someone who you're suspicious may have that cryptic shock. Put them on O2, establish your peripheral IVs. Think about adding midlines to your armamentarium. I'd still say administer a balanced crystalloid, but having those 2 newest articles are important to review and think about their generalizability to your patient population. Get peripheral pressors started concurrently with IV fluids for anyone who is overtly in shock. And then it's on us. It is a time-sensitive diagnosis, time-sensitive condition. So really just taking a step back and thinking 3 things. Is their etiology of shock due to a pump problem? Is it due to an issue with their tank? Or is it an issue due to their pipes? Considering, once again, anaphylaxis is also that pathologic vasodilatory state, and up to 20% may not initially present with those skin and cutaneous manifestations. So with that, thanks so much for getting up early, at least for those of us in the Eastern time zone. And I know some of you joining in from around the world, it's different times, and we couldn't be more thankful that you are here with us today, this morning, for our Critical Care Symposium.